Welcome to an introduction to i2b2 data transformations and the star schema. The goal of this presentation is to introduce users to the data transformation processes, also sometimes called ETL or extract, transform, and load processes, as well as the database structures used for BU i2b2. In this presentation, the video will describe how data from diverse and varied data sources are transformed into the i2b2 database by first reviewing the BU i2b2 data sources, that's where our data comes from, and then demonstrating in a simplistic fashion the data transformation processes that we use, and finally briefly describing the i2b2 star schema, which is the data structure that we use to actually store the data in. Modern EHRs offer a wide variety of data and data types for clinical research. Some of them are listed here: demographic data, problems and diagnoses, medications and prescriptions, clinical observations like height, weight, blood pressure, procedures used for billing as well as for documenting which procedures are done, laboratory data, genomic data, and quite a large variety of additional data. Our challenge really is how to transform the disparate and varied data into a standard format that can be used for all kinds of different data that's contributed from multiple sites. Our example at BU is the Massachusetts Health Disparities Repository. For this repository, we take data from multiple clinical settings, and we take multiple different types of data, and we process that data in something we call the staging area. During staging, data from these sites comes in, and all data for an individual is linked via a master patient index, whereby we know that data from a community health center for an individual is also data from Boston Medical Center for that same individual. We also do quite a bit of data cleaning, whereby we link the data from the source systems to standard terminologies. Examples of standard terminologies that we use are LOINC, which is a standard terminology for labs, CPT, which is used for billing and procedures, RxNorm, which is used for medications, ICD-9, and more recently ICD-10 for diagnoses and problems, and SNOMED, which is a clinical terminology that we use in some cases. What we're able to do is, through this staging process, convert the quite complex and varied data in our source systems into a standardized i2b2 database. And at its essence, i2b2 data is really a list of people, and currently we have over 1.4 million, a lot of facts about those people, and currently we have almost 1 billion, and definitions of those facts, also called concepts, that help us put those concepts into a context. Transforming that data is fairly labor intensive, but actually not as complicated as it might seem. And in this example, we're using the meat grinder as a metaphor for taking a wide and varied range of ingredients and putting them into a fairly homogeneous collection of data in one place. Homogeneous, at least in terms of its structure, I would say. So by way of example, I would say we had a patient, PD patient, who comes in, data for that patient comes into the staging area. We're able to see that this is a new patient for the database, has a date of birth, a medical record number, and belongs to this site. So what we do is we add that patient both to the repository and a secure link table within the staging area. The link table is never available to researchers and is protected, but is important for ongoing data translation services. But it does provide a i2b2 ID for an individual, and it also allows us to modify the date of birth by plus or minus 30 days and to include a race and sex for that patient, so that when data from the actual billing system comes in for that same patient, PD patient, we're able to see that they had a visit to PD primary care at that site, were given 2 diagnoses at the time of the visit and also given 2 CPT codes. So when we pull that into the system, we actually chop up each one of those elements into an individual fact. And so you can see that now in our database we have a person, a de-identified person, who had a service to general pediatrics, and the place where they received that service was Site 1, the PD Primary Care Center. They're also given facts for ICD-9 codes that were attributed to that visit, as well as CPT codes. And for the ICD-9 codes, since we know they were associated with a visit diagnosis that was submitted for billing, we actually assign a value of diagnosis. If this ICD code had come from a problem list in the EHR, we would actually assign it a value of problem. So in this way, we're able to pull in problems and diagnoses using the ICD-9 codes and be able to differentiate where the data came from, either the problem list or the problem list or the or a billing code. This is important because things like diabetes, for example, don't really go away. So having them on your problem list or at a visit diagnosis would mean that you have the condition, whereby some acute conditions like ear infection would probably not be on your problem list, but could easily be associated with a diagnosis that was billed for at some time. So diagnosis and problems mean 2 different things, even though they use the same codes. We're also able to link their insurance to a generic insurance type called Medicaid, but also keep the name of the Medicaid flavor that the patient has at the time of the visit on this day. And then the patient has additional data from a different site. We're able to determine that Peter patient is the same patient as PD patient using date of birth and some other features. And so we're able to say that this is the same patient getting care at 2 sites. So all we have to do is add that second site to our link table and not change anything here. But then we're ready when new data comes from the second site for a visit that is linked to this medical record number that says they had a visit to pulmonary clinic and received a diagnosis at that time. So then we pull those in as new facts about that patient, a service to pediatric pulmonary that was at Site 2, PD Pulmonary Clinic, and also that person at that time received an a diagnosis as well. And then finally, when Site 2 actually does a lab test, and the patient receives a hematocrit and an MCV that actually has values, we pull those in, and linking those to the LOINC terminology, and actually LOINC uses numbers, not these letters, but I've put the letters here to make it clearer, and then we assign the actual numeric values. So some values are text-based, some are numeric-based. We're able to use standard codes. We know when the code was recorded, and we know where the data came from, and we're able to combine multiple sites and multiple databases, data types in a single table. And what that allows us to do is using collections of facts called ontologies, we're able to easily in i2b2 search through the ontologies, drag them over, and run fairly simple queries. So this is an example of someone was asking how many patients currently in the database are 45 to 64 years old. We get to those age concepts, we pull them over, we click Run Query above, and we come up with a number of 293,000 plus. And so in this way, pretty much facts here are able to be explored using dates, the number of times they occur, whether or not your query is to include these people or exclude these people, and within the hierarchies to lump certain facts together. And that really is the essence of the i2b2 database. And when you actually look under the hood at the data schema, i2b2 uses the star schema, and in essence it's really just a list of patients, and for individual patients they have a de-identified repository number. They have a birth date. We don't typically collect death date, but it's theoretically possible to put it in there. And then they have a short list of demographic features that can be used to group individual patients by certain things that don't tend to change for an individual. And then we have a very large number of facts that go into this single table that really is just a concept code, like a lab test or a visit or a diagnosis, a start date, and a patient number, and then some other things as well. And we're able to store character values and numeric values separately, and to know that this is a type of fact that has a numeric value or has a text-based value. And then there is a concept dimension table that describes the concept CD much better, so you can understand how the things are organized in i2b2. And in some cases, we lump the facts into facts that occurred in relationship to a certain visit. And so it's possible to clump the facts together. i2b2 does also support a provider table that would eventually allow us to link individual facts to the providers that were responsible for those facts, but currently we don't collect the provider identifiers in the system. So I hope this video has been helpful. In this video we tried to describe how data from diverse and varied data sources are transformed into the i2b2 database. We first reviewed some of the BU i2b2 data sources that we have. I then demonstrated how the data transformation process works, and finally I gave you a brief overview of the i2b2 star schema. And in this way I think you can understand how a complex and varied collection of data can be organized into a well-structured, standardized data format. Thanks for listening, and please let us know if you have any questions as you learn to use i2b2 at BU.